I just want to thank everybody here for coming. I kind of get a little quiet about this. First of all, I have no disclosures. The objectives for this talk are stated and actually changed a little bit. As the wonderful thing about PowerPoint is you can change it till the morning of your presentation. It's also the worst thing about PowerPoint. Any talk at a Richard Schwartz Symposium should be about a little bit of history of education. Richard was a true mentor to me when I got here and took me under his wing and showed me the ropes of how to be a better teacher, how to be a better surgeon, how to be a better doctor. And all the time you show up after 10 years of residency and fellowship and you think you know a lot, and then you meet somebody like Richard and realize you still have a lot to learn. Halstead at Hopkins really started the apprenticeship model of surgery in 1904. And the concept of greater responsibility was something we take for granted, started then. Flexner Report set standards for curriculum for students, and 3 years later, the Clinical Congress of Surgeons North America did the same for surgical trainees, and if you don't know that, that's where the birth of the American College of Surgeons came from in 1913. The Halstead's principles of surgical training are still proposed today. The resident must have intention, repetitive opportunities to take care of surgical patients under the supervision of a skilled surgical teacher. The resident must acquire an understanding of the scientific basis of disease, and they must acquire skills in patient management and technical operations with increasing complexity with graded enhanced responsibility and independence. Things that today in 2017 are probably not very well thought of if you're not in the trenches with surgical residency and education. Apprenticeship model. Evaluations are mostly observational. Trainings learned by repetition and trial and error. But when you're with them 24/7, you got plenty of times to make observations. In my experience, I have, as I'm doing this thing, I looked up from my office and said, okay, who were my teachers as residents? And I had 3 people who were completely different, but mostly equally important in my development. My coach was Tom Crummell. Tom Crummell was division chief of ped surgery, became the chairman, and then went off to become the chairman at Stanford. To this day, if I have a career question or something like that, I'll email Tom and ask him what's going on. He's the 30,000-foot view, always the cheerleader, always the coach, always telling me I'm doing great, doing awesome, keep going, doing great. Bob Conter in the middle there was my drill sergeant. Bob was the guy who spent a philosophy of the first 3 years of residency, we should beat the shit out of you. And beat you down to a pulp and then remake you in your 4th and 5th year into a doctor. And there wasn't a day I went by in the residency I didn't love and hate the man at the same time. But every year at the American College of Surgeons, I make sure I find them, have a beer with them, and say thank you. The technique and care guru, and the guy who actually made me a surgeon, was Bob Silley, who's now the division chief and surgeon chief at Children's Hospital at Hershey. And yeah, I'm a ped surgeon, but it wasn't the reason why Bob Silley's my mentor. He's the guy that sat me down and looked at my evaluations and when they said, hands of stone should be a pediatrician. And they were right. But he took the time to make me into a better technician. He made me close a wound one time 5 times. Kept cutting it out. Common variety of needs of what I needed to be a resident. The common denominator was time and one need to be better. So the evolution of surgery education, as you go through, it's a little bit important to understand this. The ACGME wasn't formed until 1982. In 1999, because people wanted to kind of make standardized training across different residencies, surgery did this, medicine did that, we came up with these core competencies. I bet if I quizzed all of you guys on what the 6 core competencies are without reading them, you wouldn't be able to recite them, okay? But yet that's what the basis of your evaluations are supposed to be on, right? Work hour restrictions became standardized in 2001. And in 2002, the SCORE, the Surgical Council on Resident Education, tried to come up with what was the first national curriculum in general surgery so that everybody had access to the same curriculum via portal, online education materials, and now simulation. The curriculum is the ACS Fundamentals of Surgery curriculum, the Fundamentals of Laparoscopic Surgery, and simulation curricular at every residency, which hasn't been standardized, but hopefully will be soon. Some stats on surgical education right now. Last time I could find a complete set was in 2011. There were 1,150 positions, 40% females. Caseload requirements are only 750, down from 1,000. Chief cases required are 150. Of the 60 months training, 54 need to be in clinical rotations. So the total time in residency has not changed. Fellowship training. In 1992, the year before I finished medical school, was 50%. So half the residents graduating went into private practice, half went into resident fellowship. In 2011, it was up to 80. In 2015, there was one report of 84% of residents are going into resident training, not completing the training after 5 years. Attrition rates is something that people argue back and forth. There's finally a good paper that just came out this year that the total rate is 8.8%, but there is definitely a change and a difference if you look at different residencies. No one can attribute the cause, but there are definitely residencies that have higher attrition rates than others. It has nothing to do with gender, where it is, what metro it is, but there are definitely some that seem to do better at keeping residents than losing them. Lots of changes taking place in education across student and resident forum. What are the forces? Public is the major one, and it's the public demand to change for the 8-hour work week. They don't want tired doctors taking care of them. They want proof that their doctor's competent. So it's not just enough for some curmudgeon surgeon to say, oh, this person can operate. I want proof on paper. I want a formula that says that this person's fit. Greater accountability and safety, and no acceptance for error anymore. Remember, the Hall studying principle is that you learn this by trial and error, yet public says we can't accept any errors anymore. So where's the rub? Costs. Well, let's do it with simulation. That costs new technology simulation costs, databases for evidence-based care costs more money, reimbursement keeps dropping. Time's the same. Favorite residency line, you can't stop the clock, I'll be out of here in 5 years, okay? That hasn't changed. But the amount of quality time that we spend teaching each other, I mean that each other, is decreasing. Learners want instant feedback. They are very cognizant of the fact that because they have decreased time to learn, they want to minimize their service time and maximize their education time. With the ever-increasing complexity, we have increased numbers of patients who are sicker. We don't have the gimmies anymore. Okay? The quality of the presentation so far, nobody was a standard gimme on the presentations yet today. I'd like to say those are the exceptions to the rules, but going to M&M every week, they're not. There are common patients. EMR, competing for your time. I love when I read EMR papers. I looked at 15 of them last night, trying to find one that proved my theory that it takes more time. But they also deny that it takes decreased time for documentation. Once your learning curve is established, you'll do just as well. However, it's the most cited cause of physician burnout because guess what? It takes more time, takes more effort, and leads to more frustration. All these quality and safety initiatives, the alphabet soup that we never had to worry about as residents, monitoring activity involves data collection, more time to EMR, more time, more I's to dot and T's to cross. The work hour restriction is the most common thing cited that works is the continuum of care. You get a staccato experience of disease states and operative exposure, and the best UK example that frustrates all of us is the ESS resident rotation. Why the same resident who has to do the workup, who diagnosed it, can't get the value of going through that operation in the middle of the night and doesn't know because they have to go do the next operation. Can't fix it, but it does give everybody frustration. And there's call for more, in spite of all that, we want to evaluate better. We want to have more data. So we have now real-time evaluations, we have 360 evaluations, we have a simple app, we have online stuff, and we still have rotation evaluations. All this leads to more documentation and more data. Is it better? Or is it more time for documentation and actual observation and actual teaching? So this is the result. One thing that observed though is that practice surgery is still a craft. It requires cognitive skill, judgment, and physical skills. All require repetitive experience to master patterns. The framework of skill acquisition still hasn't changed. It still hasn't changed in surgery, hasn't changed in sports, hasn't changed in music. Repetition, repetition, learning how to craft, be a master of your craft. Mentors, all of us talk about mentors, and everybody talks about a mentor if you learned how to play piano as a kid, if you learned how to play baseball, who taught you how to throw a curveball, who taught you how to do this maneuver in the operating room. Your time with your mentors is decreasing. Observation data points are now limited. If Bob Conter was my mentor now, and all I could see with him is within an 8-hour work week, I'd probably get all the bashing and never have the time to go back and finish the circle and watch how he built me up during my 4th and 5th year. Resources are expensive. OR time is too valuable, according to the suits, to permit acquisition of basic clinical skills. Simulations have been shown that acquisition of skills are transferable over. That's awesome. Who pays for them? And the time in simulation is rarely with a master mentor to show you when you're throwing that stitch right. You're just in there by yourself, or you're in there with a lab tech putting foam together, and you think you're doing it right, and you get the O and find you were doing it wrong. You practice it for 10 hours doing it wrong. Competence-based advancement rather than observational assessment is the norm. So what's the problem with us? What's the problem with the teachers? We have sporadic encounters with learners, limiting opportunities for substantive feedback. The rotation system allows less longitudinal contact. We have less contact with you to get you a whole circle of evaluation. Efficiency hours are a requirement, or in some cases, at least in my experience, an excuse. And I'll admit to that. Variability in clinical acuteness, volume, and breadth creates barriers to standardized evaluation. It's hard to try to set you through the easy appendectomy before the retrocecal perforated one. Well, you can't pick which one's going to come in first. And fear of negative feedback. As a clerkship director, the most common thing I get from the faculty on the curriculum committee and the education committee is, I don't want to give a negative evaluation. I may have to go to another meeting and prove why I gave that negative evaluation. They feel, and good reason is, they feel they have a too small sample. Maybe it was just a bad day. Maybe this is I don't want to grade this person harshly because they may have just had a bad day. They don't have enough observations. Where's the value? Still the most common assessment is faculty written feedback, whether it's online, paper, we can make it whatever we want, but it's still faculty written. The goal is reliable feedback. Multi-institutional data shows that it's too subjective, it's too variable, it reflects recollections with a usually small sample size, and is infrequent, has critical appraisals of clinical skills because of what we just said. So here's the dilemma of selection learners and teachers, which I always put up when I teach this talk. The surgeon observation is you do everything you ask. You read, you know patients, you write your notes, you operate at an appropriate level, you do everything you want. You may be a surgeon someday. Thanks for showing up. Thanks a lot. Go to your next rotation, you're okay. Silence is positive feedback. I'm sure every one of you heard that from me at least once in your residency. The millennials do everything asked from the service, read, know patients, write notes, operate at an appropriate level, present on rounds. Man, I'm a rock star. Hire me to the faculty now. Tell me what I did well. Don't tell me what I did wrong. What do our learners need? What do our learners want? The optimal teaching environment is called feeling included, like part of the team. Feeling like the part of the team, but every teaching mode shows up, everybody's included. They always want to perceive that they're performing ahead. They want to say, like, I'm doing better than my peers, right? Doing okay. They want to have tasks delegated to them and really accepted and protected and trusted that they're going to be done well. We live for our feedback. We want to know what we're doing well, what we need to work on, but being ignored will serve no purpose. But they really want to know what they do well. They have constant, instant feedback in life. We all do, okay? Twitter, Yelp, pick up your phone. How many of you have Twitter feeds right now? How many are Twitter feeding this conference right now, okay? This best compliment is silent stuff that comes from the curmudgeons like us doesn't always work. Negative feedback is okay as long as it's not the only feedback. And as long as the learner comes with this self-evaluation ready to accept it. Front expectations are more helpful than after-the-fact reviews. Today I want you to do this. Today I want us to learn this together. Teachers often don't know what's expected of learners. Expectations do not match. What I should expect from a first year should not be what I expect from a third year. Sometimes we expect differences based on personality or based on perception of that resident before they get to your rotation. So there's denial on both. Faculty will say, I give constant feedback. Grunting doesn't count, guys. Negative feedback alone only alienates, so I'm guilty of that, okay? Learners, I never get any feedback. Correction is feedback, and self-assessment is important. Looking at yourself in the mirror and say, how can I do better on both ends of the occasion? Faculty presents that you're here to learn as you work. Learner is, we're here to learn, but we have a job to do. So we got to remember that the glasses looks at it completely differently from either side. So the perfect storm is at a time when learners are programmed to feed on positive feedback and follow guidelines and follow rules, the time for meaningful observation to be able to tell them what they're doing right and what they're doing wrong is shrinking. We're programmed to be efficient and safe, make a quick assessment, observe, then get the case done and get on. You got 4 more to do that day, and with turnover you're not going to be able to do it unless you hustle. Students, I need repetition to show improvement. I need to be able to show you that I know I need to hold it right, but give me another shot. Well, we can't, we don't have time. So they tend to be hesitant, passive, and you're going to yell anyway, so why should I even try? So here's what usually happens. It's frustrating on both ends, but it isn't. So what's the common ground? Learners, what skill do you want me to learn today regardless of the service? Let me know in real time. Give me rules and I'll follow. One thing that I've been very impressed with is if you give somebody a bar, they'll make it. If you make that bar too low and your expectations are to go above the bar, it's your fault for not raising the bar high enough. Faculty, what do we need to assess? How do we assess it? How can I be efficient with observations and assessment and not add to my compounding daily cadre of things I need to do either on email, phone, or in paper? Understand assessment being part of overall learning. Understand that we're not being able to assess the entire picture anymore. We're going to have to assess snippets. Just like they're learning in snippets, we have to assess in snippets. Just what to say, you just want to say, hey, you're doing fine. You're doing okay, don't worry about it. Well, no, I want to know what I'm doing right, what I'm doing wrong. So that gets into, the only clinical part of this talk is what is the difference between different assessments. Formative assessments is something you do immediately, daily. They're in the little snippets of active engagement. The student has a self-assessment. You say, okay, at the beginning of the case, today I want to watch you do the dissection of the cystic duct and see how long you take to do that. If you keep doing that efficiently, we'll let you go. Otherwise, I'll take the gallbladder off the bed. Observation is of the process of learning from the day to day. Summative assessment is at the end. When you have 5 or 6 different repetitive assessments and observations, you can even now give a global assessment. You need both. The student will watch and be passive for the summative assessment, but they should participate in the forms of, hey, am I doing that right? Am I doing that wrong? As opposed to, at the end, getting a whole assessment. So now, the one thing that, again, what are we doing? We're bringing in one more piece of paper, one more way of assessing, but now we're trying to see if we can assess all these things at once and do both formative and summative assessment at the same time. EPAs are the new common behavior described by the AAMC for all graduates. It's being integrated in residency and student education, even though it was supposed to be just for graduates. Now it's all the way going down to the med student level this year. It's a unit of professional practice defined as tasks or responsibilities that trainees are trusted to perform or supervised. They're more easily identified. Do you still need to be an MD or a doc in individual practice? For example, if you want to assess the EPA of treating a wound, you have to assess it, examine it, make a decision, repair it, teach the family, and do follow-up. It's got all the core competencies in one thing. Multiple competencies are assessed, and multiple application of the duties of the surgeon. If you can treat a small wound, you can then progress to treating a deeper wound. What about competency milestone? They're all integrated. So the benefits of EPAs are that they make sense to the day-to-day activities. The bad things that they're new and that they're harder to assess. They're a global assessment. The competencies are what we've been dealing with for over a decade, so people are kind of used to them. When combined, they do define a good physician. So now the EPAs are trying to combine them together and make it a little bit easier. The competencies, as I always say, they're very abstract. Well, is this knowledge-based? Is this performance-based evaluation? I don't even, we kind of try and make up where they go. So what is a pre-entrusted learner? What is an entrusted learner? So a pre-trusted learner is someone who's coming in new. They'll come in and they'll gain some milestone. They'll be able to hold a needle driver and throw a stitch. The competency is they'll be able to close part of a wound. The domain of competence is I can now let them close that part of the wound on their own. The EPA is I can let them go assess the patient who has a cut and trust that when I go back in, they're going to assess, clean out, infiltrate, close the wound, and have it dressed, and I don't have to take the dressing down because I trust them. So it's both formative and summative. It gives you the ability to do real-time assessments during the process as you're watching them become competent. You watch them more closely, but it allows them time to improve. At the end of the unit, an overall assessment measures completion of their skills. So it allows both evaluation types. So in history taking would be another example. The evaluation form, it's hard to see this, but each one of these questions, this is a student evaluation form, but it's going to be similar for residents. Each one of these things has the same answers for different questions. So the teacher gets easily identified a description of what skill level depicts each level, and the learner gets feedback that makes sense and can be applied to other settings, other rotations, other evaluations. And if you look at it, everybody's talking about simple, and we talk about the swish model of learning. We talk about show and tell, active help, passive help, supervision only. Well, EPAs are essentially the clinical correlation of the simple model. Cannot perform, so you got to do it for them. Close supervision, minimal supervision, independent can teach. So again, we're going to have a basis that we can do both clinical assessments, medical skills we can do for operative assessments. If we think about it that way, it should be easier for both of us to understand where we each are on the education paradigm. The hope is that the common knowledge assessment tool allows both sides to understand and can build competence, experience to competence, or to my hope, mastery, not just competence. So is there a time to teach? Yes. You got to be patient, approachable, and humble. Take the opportunity. Point out the good, encourage, but be honest. Remember, daily snapshot is a small part of the big picture. Understand that observations are small and our assessments need you to reflect what you see now. They're not the final product. Learners need both formative and summative in order to provide complete understanding. And one of the faculty members in the audience is described as this almost every year when I read evaluations. I always know where I stand with this faculty member. She would teach me in every situation. And Courtney Lee, thank you for having that every year on your evaluations. What can learners bring? You understand that evaluations are hard to do. Feedback won't always be positive, and that's where you got to look in the mirror. Negative feedback actually statistically and psychologically is usually more helpful because you remember those. And surgery topics usually continue until knowledge base is exhausted. That's part of the game. Okay, we continue to ask you questions until we find out what you don't know. Seek out evaluations only if you want one, okay? If you don't want the evaluation, don't go get it. And be honest and critical self-evaluators. So the take-home message for all is provide a framework for each other, learn through greater responsibility, communicate expectations on both sides, provide positive feedback to each other, and navigate failure when it happens, because it's going to. And that's one of the ways you learn. You always learn more by failure than by, you get it right the first time. Thank you.